Or is somebody else? We should probably have found out if we're advancing slides or somebody else is. Yeah, that's not working. Maybe she's advancing them.
So the easiest way is just using these arrows, except they're not working. Let's see. Oh, yeah. So, arrows? Yeah, there was a clicker thing, but it seems, let's see if that works. If you prefer the little clicker.
I'll just use this.
Arrows are fine.
Okay.
All right, so I'm just going to do you and then off and running.
Okay. Right. Oh, sorry, Katie.
I think a lot of people in the lobby.
Yeah, no, we can give it to you. Okay. Good luck. It's going to be fun. Yeah, I will. Yeah.
We'll get started here in about a minute. There's some people in the lobby grabbing some food. Welcome, everybody. If everybody could find a seat here in the next few seconds, that would be great. I'm just going to stand here and stare at you all for a little while. Thank you all for coming. It's a great turnout. I'm really impressed with the level of interest in this. And I also want to thank everybody joining us virtually through the webcast. I think that we had over 150 people registered just for the webcast. For those of you on Twitter, we do have a hashtag, whatever that means. So please follow us along, again, whatever that means. I was told to say that. Before we start, I'd like to thank Katie Murphy, Laura Hendricks, and Andy Lee, and others that helped arrange all of this. For those of you who don't know me, and people patching in virtually maybe not know me, I'm Tim Beebe. I am the head of the Division of Health Policy and Management, one of the 4 divisions within the School of Public Health, the others being epidemiology and community health, environmental health, and biostatistics. But I think there's a fair amount of agreement that, you know, we're the coolest division of the school. As you know, the University of Minnesota is a land-grant institution, and in keeping with that land-grant charter, the division has dedicated itself to translating knowledge from our research that the faculty and staff have done into practice and policy on matters that impact the health of Minnesotans and the nation. And further, as we were reminded from a message from our president, President Kaler, over the weekend, we have a long history of engagement as well at the local, regional, national, and global levels. So, where was I? Just kidding. Yeah. Okay. It's like crickets. So the panel today was pulled together in the spirit of those of engagement and translation, and in honor of those 2 institutional imperatives. So moving on to the topic of today, as you know, unless you've been binge watching all 6 seasons of Dawson's Creek for the last few weeks, the healthcare has been on large part of the national conversation since the election. Primarily the repeal and replacement of the Affordable Care Act. The faculty, a large number of our faculty within our division, and our division has about 40 faculty, about 80 staff, and about 400 students in our educational programs. It's nice to see some of you here. And a large proportion actually do a amount of research in health insurance and healthcare. But more importantly, they have been at the table in identifying and crafting innovative solutions to issues around healthcare and health insurance for policymakers, practitioners, and patients alike. Today's panel is an extension of that latter work, that translational work, where a select segment of our faculty will be chiming in on what's next in healthcare based on in these changing times, and kind of viewing it from their different perspectives in terms of their research interest and foci. My hope is that you find this experience informative, understanding what might happen, why it might happen, and what it might mean to you. My plan is to have a number of these types of panels over the coming months as complex challenges emerge and important discussions need to take place. So stay tuned. This is going to be ongoing dialogue. My goal of this is to remind our stakeholders, including the public, that this school is a source for even-handed, objective, evidence-based guidance and insights on the most pressing health issues facing Minnesotans and the nation. So that's a little bit of table setting. Now let's move on to the much smarter people on this dais, starting with the smartest. It's my pleasure to introduce Jan Malcolm, who is going to serve as our moderator today. I've known of Jan Malcolm since my days as I worked at the Department of Human Services in the late 90s and early 2000s. And I don't think I ever met you, but I knew a lot about you. People always described her in the most salutary ways, energetic, strategic, effective. And as I have come to know her better through our respective appointments here at the University of Minnesota, I see them on display and manifest, and they exist in abundance. So She now has an adjunct faculty appointment in the School of Public Health, where she is co-leader with Michael Oakes and working with Sarah and Ezra on a national leadership development program funded by the Robert Wood Johnson Foundation, and she also teaches public health leadership. She was most recently Vice President of Public Affairs and Philanthropy at Allina Health, where she oversaw the offices of philanthropy, public policy, and community benefit in their work for external partners, including donors, state and government community leaders. Since she was Commissioner of Health, between then and now, she had a number of leadership positions at the Caney Courage Center, at Courage Center, and Robert Wood Johnson Foundation. Throughout her career, she's been active in state and national healthcare and public health associations and government commissions on healthcare access and quality. And she currently serves on the board of Stratus Health, Blue Cross Blue Shield of Minnesota, and Blue Cross Blue Shield of Minnesota Foundation. So I can think of no one better to serve as moderator for this important session, and I'm kind of surprised she accepted my invitation to do so. So with that, without further ado, I'm done talking now. I want to hand it over to Jan, and I want to welcome her to this role and to this lectern with a round of applause.
Well, thank you, Tim, for that very generous introduction, and good afternoon. Thanks for joining us. It really is a pleasure to be part of this panel and to introduce you to these extraordinary resources that we have in our community. These guys really are deeply knowledgeable about some of the things that is so important that our policymakers, whether they be at the federal or the state level, should really understand. And we, as citizens and health policy people and health advocates, should understand about what's at stake in this debate about where we go from here with healthcare. So the ACA, there's a lot to it. We're starting with the coverage dimensions of the ACA today for good reasons, but I think, as Tim alluded to, we hope to do more of this kind of panel format to probe other dimensions of health policy in the state and nation, and the consequences of ACA replacement and repeal. But so the ACA, it is either the end of democracy as we know it and an unmitigated disaster that should be repealed every line of it, or it is responsible for actually moving the health system in America in a more sustainable direction along the goals of the triple aim, and even having a positive impact on the economy. So there are competing ideologies, certainly, but competing data and competing anecdotes about what really has been the effect of the ACA. So there's a lot to it. I think for us as a public health community, for me, almost the most important part of the ACA is that for the first time, we've got a framing of national health policy around population health. That's huge. That has never happened before, and I personally think that that's key, keeping that population health frame in mind to wherever we go from here in the national health policy debate. But coverage is a very, very logical place to start. It's certainly what the public relates to the most and cares about the most in terms of what's salient in our day-to-day lives. We know there are many, many other issues that are important to attend to, but coverage seems to be a logical front door to all the other issues. I have a very vivid memory when I had the privilege of serving as the state health commissioner during the time when, and certainly we've known for many years, people in this room have known for very many years, that quality in healthcare is a real issue and a real opportunity. That's not been publicly known for very long. When it first started to become more in the public consciousness that we have quality issues and should be doing something about it, we at the health department were trying really hard to get the legislature more engaged in health quality and to see that as a policy priority. And I so vividly remember the leading health policy person in the Senate, Senator Linda Berglund, saying, you know, I hear you on health quality, but quite honestly, until my constituents have access to the care they need, I don't want to talk about it. And that, I think, is sort of an encapsulation of what is true politically about this debate today. That the thing that is most on people's mind is, can they get access to the system when they need it? And then we should talk about value and quality and population health and prevention. But that front door of, can I get what I need when I need it, is salient, and for good reason. So that's where we're going to start with this panel today, talking about coverage. Oh, Katie, we timed out here. Can I get your password? Sorry. not your email password, but I only need this because the intros of the panel are on here. But so that's a little awkward. There she comes. Sorry about that, Katie. So I will continue to just vamp for a minute, so you don't have to announce your password to the whole room. Thank you. Or the hashtag. Yeah, explain hashtags, because I don't understand them either. That's, Tim, I'm so glad you fessed up that you're not part of the current generation either. Thank you. Thank you, thank you. Okay. So I'm just going to introduce you to our distinguished panelists. I'm going to just tell you a little bit about each of them, and then they are going to go kind of in order for just a few minutes thanks so much, to kind of give you literally about a 5-minute or so synopsis of what they think some of the important issues are in this discussion of coverage in the ACA. And then we're going to have some questions, and we really hope to save a great deal of time for your questions. So we're going to move quickly through a very high-level overview. So introducing the panel, Jean Abraham. Dr. Abraham is the Wegmiller Professor and Director of the Masters of Healthcare Administration program here in the School of Public Health. Jean's research focuses mostly on employer-based health benefits, including insurance and wellness program evaluation, the individual market for health insurance, and evaluating the impact of the Affordable Care Act on both employers and insurers. In 2008 and 2009, Dr. Abraham served as the senior economist on health issues with the President's Council of Economic Advisors in Washington, D.C. So she was very much on the front lines of this issue as this policy was taking shape. Jean earned a BA in economics and political science from the University of Arizona and her PhD in public policy analysis and management from Carnegie Mellon. Dr. Lynn Blewett is Professor of Health Policy and Director of the State Health Access Data Assistance Center, lovingly known to policy wonks as SHADAC, here again at the School of Public Health. SHADAC is a research and policy center focused on insurance coverage, identifying barriers to needed care, and state and federal reform. Dr. Blewett was the lead of a research team funded by the Robert Wood Johnson Foundation to provide data analytics and support to states implementing the Affordable Care Act. She also directs the SHADAC evaluation program, which provides funds to support state health policy research. And she's been engaged in state health policy for over 20 years, including a time at the health department as our state health economist. She currently serves on the board of Portico HealthNet, which is a coverage program for the uninsured, and recently served on the National Academy of Sciences consensus report on assessing prevalence and trends in obesity. Next, Dr. Ezra Goldberstein. Dr. Goldberstein is Associate Professor of Health Policy and Management at the School of Public Health. His research focuses around health economics, mental health services and policy, healthcare financing and cost, and non-medical determinants of health. Ezra earned his PhD in Health Services Organization and Policy from the University of Michigan and completed a postdoc research fellowship at Harvard Medical School. He is, as Tim mentioned, an Associate Director of the Robert Wood Johnson Foundation's Interdisciplinary Research Leaders Program. And Dr. Sarah Gollust is Associate Professor, also in the Division of Health Policy and Management. She's also another Associate Director of the Interdisciplinary Research Leaders Program, which aims to support both researchers and community activists to build a tighter bridge between research and community change, particularly around the social determinants of health and health equity. Leveraging theories and tools from communication and political science, Sarah's research examines the roles of the news media, communication, and public opinion within significant health policies, including obesity, health disparities, the ACA, and cancer screening. So we have a really excellent panel with very direct research and engagement experience in all of these topics. So we're going to go down the row and start with Jean, from sort of a high-level federal perspective on what was being attempted in the ACA and what do we know about coverage.
Great, thank you so much. So it was about this time, about 8 years ago, that the Obama administration was transitioning and agenda setting. After a couple weeks' time, they decided that healthcare was going to be their top domestic priority and really laid out two clear objectives of what they had hoped to accomplish. The first was to reduce the number of uninsured Americans. Think about it. In 2009, we were in a recession. There were about 17% of Americans without health insurance, about 50 million individuals. And we really were many individuals were very vulnerable to losing their coverage as a result of the economic conditions. As we know, of course, health insurance provides really important financial protection against uncertain healthcare shocks and the expenses associated with that. We also, as part of the objective of reform, was to introduce policies that would help to contain healthcare cost growth. So there was a recognition that there needed to be reforms in the delivery system to try to shift incentives and maintain costs. Here in this country, this year, we will spend about $3.2 trillion, or about $10,000 per capita. Of course, as we all know, there's a very uneven distribution of spending. Most people spend about a few $1,000s or less per year, but a small proportion of the population consumes a very large portion of dollars. In fact, the top 1% of the population consumes about 20% of aggregate spending. So what has the ACA accomplished with respect to these goals? Well, we know that a two-pronged strategy was used to extend or expand coverage. First, through the expansion of Medicaid eligibility to those with incomes up to 138% of poverty. We know that states could opt into this, and as of this year, 32 states, including Washington, D.C., had expanded. We know that about 14 million people are newly enrolled in Medicaid, 11 million of whom are newly eligible as a result of the ACA. The ACA, the policymakers, as they were devising the legislation, also sought to use a private market approach to expand coverage to those who were at higher incomes but still would face significant financial burden in terms of paying premiums, and that was through the use of premium tax credits and cost-sharing subsidies in newly created marketplaces or exchanges. We know from literature that about 13 million people are in the marketplaces, although not all of whom are newly insured. There was also a lot of discussion around the need to address deficiencies with the individual and small group markets, particularly around the issue of access to insurance or affordable insurance by those with pre-existing conditions, as well as the high administrative costs in the individual market. Some estimates put that at 40% of every premium dollar was going toward administration and profits in the individual market prior to the ACA. And finally, consumers were having difficulty with shopping for individual coverage because every product was different, and the quote that you might get online was not the quote that you would face due to medical underwriting. On the containment of healthcare spending growth, the ACA provided important investments in developing new payment models that would shift provider incentives from volume to value. So things like the ACOs, Medicare Shared Savings Program, bundled payments, among others. One thing that was interesting as I worked in Washington was the question often came up, even if something didn't pass in terms of legislation, would that shock the private market enough to induce change? We saw that happen in 2003 and 4 when the the Health Security Act failed. We saw some shifting. I think it's also true under the ACA that there's an acceleration as a result of public policy. So, of course, times are a little bit uneven today. We have some wins around the number who have gained coverage, mostly low-income Americans, and some new rules in place. But it's been a rocky road, as we all know from the media, with respect to the implementation of the marketplaces, and most recently the rapid premium growth in the individual market, where we know that middle-income earners, those who are not going to qualify for as much subsidy, are really being taxed in terms of out-of-pocket costs. And then more broadly, I think we're starting to see a bigger discussion around insurance benefit designs and what is the amount of financial protection that individuals have with their policies, whether that's in the individual market or other private insurance. So as we look ahead, clearly with the election, there is a change in direction and a call for repeal and replace by the Republican-controlled Congress as well as the President. We're currently in a period where there's a lot of activity going on. Not all of it is transparent to us, but we have some good ideas of what direction things are likely to head. So with that, let me stop and pass the mic to Lynn, who's going to share some observations about the state of Minnesota.
Good afternoon. Thank you so much for coming. I appreciate the opportunity to speak with you. I think what I'd like to cover is just some of the impact that the ACA has had on Minnesota. We have traditionally had a pretty low uninsured rate, but even prior to the ACA, our uninsured rate was growing. It was 9% and growing, and there was concern about what's happening in our market and where were people going to get covered. So with the impact of the ACA, we're at a low of 4.3% uninsured. When I worked for the state of Minnesota, we actually had legislative language that said 96% of coverage was universal coverage. That was our definition of universal coverage. So it's something to think about. I think on average we're doing very well, but we also need to recognize there are pockets of uninsurance, both for people of color, for new immigrants, and then pockets in the rural areas and inner cities. So 4.3% is on average, and there are areas and populations that have much higher rates of uninsured. So I don't want to sit back on our laurels, but that's the ACA helped us to reduce our uninsured rate by almost a half, insuring over 200,000 more people. One of the things that I want to also emphasize is the ACA has brought about $2 billion to Minnesota in terms of our coverage programs. And these are programs that have traditionally in Minnesota been paid for by state-only funds. So many of our programs we had designed bipartisan support for and funding for programs like general assistance medical care, for low-income adults without children, for our Minnesota Care program, which we covered up to 275% of the federal poverty level. That was all state-only dollars, which we agreed to as a bipartisan legislature. And then also we covered kids before the federal Children's Health Insurance Program. So as a state, we've always been sort of at the forefront of thinking about coverage and have committed state dollars to those programs. Now, with the ACA, we've been able to replace a lot of those state dollars with federal dollars, up to a tune of $2 billion. And so we can't, the federal money has really supplanted the state dollars. Now, if the ACA were repealed, and this is a concern that I particularly am concerned about and worry about daily, is our 2% provider tax, provider assessment, which we have used to fund our Minnesota Care program, that is legislated to be repealed or to sunset at the end of 2018. And so we won't have state funds to fund those programs. So if the feds take the money away, we would have to start from scratch. So we wouldn't be going back to pre-ACA, we would be going back to like the 70s. And so we'd have to start to rethink sort of what programs that we want, what programs as a community we want to fund, and do we have the resources to fund those programs without the federal financial contribution. So it's not only the public programs. We get almost $200 million are in the federal subsidies on the exchange. And so that's another place where people are getting federal subsidy support. And then also on our Medicaid expansion. So the federal government provides matching funds to the state for Medicaid at about a rate of 50%. That's like the lowest. It's the floor. You can't get any lower. State like Mississippi or Alabama, they get more like 75 or 80% match. So for every dollar they spend, the federal government pays 80% of that. Well, in our expansion population, the federal government paid the full cost for the first years and then down to 90%. So it's kind of a good deal. The federal government's paying 90% of those for the expansion population. So So I guess, you know, it's a matter of coverage, it's a matter of resources, we all should be paying attention to what's going on with the discussion at the national level. The third major area of impact is on hospitals and the uncompensated care. So traditionally, where do people go to get coverage who don't have insurance? It's community hospitals and emergency rooms. They currently receive about $548 million they've gained in reduction in their uncompensated care. So that's like dollars into the system. And so we're talking about a significant amount of resources. So the individual market is clearly not stable here, and it's actually on the verge of collapse if we don't do something this session. The problem now is we don't really know what the feds are going to do. So we don't know what Congress is doing. We clearly don't know what the new president is thinking. He seems to change every couple days, and the Republicans don't have a cohesive plan. I guess at this point, I'm advocating that the legislature think about a bridge policy for like 2 years, like let's pass something for 2 years and wait till the feds pass something and we have more information about what will be good for Minnesota. And that bridge strategy that I'm envisioning is possibly extending the rebates that were just passed by the legislature and signed by the governor to think about. The problem is if we do a reinsurance or a high-risk pool, you jeopardize funding for the Minnesota Care program, and we can talk about that. It's kind of complicated, but to maybe just extend the rebates for a few years so we maintain our federal subsidy levels, maintain funding for the Minnesota Care program, and then think about extending the 2% provider tax again for a period of 2 years until the federal government, for the Congress to act. We can talk about some of those details, but I think the market as it stands right now is in such flux that there's nothing we can really do in the short term that's going to stabilize it if we wait until Congress acts. I also think if and when they do act, there's going to be an implementation period, and there has been discussion if they pass something, it won't be implemented for a year or two. So there does, again, give us some opportunity to get our act together and figure out what would be the best for Minnesota. I would just like to say most of us, in conclusion, are on the Twitter, and we are very active on Twitter. In fact, Ezra had his Twitter open. I said, you know, if you miss an hour, something might have happened. So please follow all of us on Twitter, and then also if you're following, feel free to tweet out. Things are moving so fast. It's kind of the one place where you can get information quickly. It's a little bit of information overload, but things are happening on a day-to-day basis, and it's one way to keep up to date. And there's a lot of really good, smart policy wonks, as we call them, that are keeping track at the national level that we all follow. And so it's a way to keep our fingers on the pulse of what's going on. So I encourage you all to engage and ask questions, provide information. The legislature needs your voice, that you're watching, you're paying attention. There's some things we could do that would really destabilize our market and also be a concern for coverage and access. So it's a really important time to pay attention to what's going on. So thank you. Ezra.
Hi. So I'm going to be focusing, at least my initial remarks, more around the issue of mental health and substance abuse in the context of the ACA and where we're at right now in mostly federal health policy. This is for two reasons. One is that this is just a big area of research interest of mine. I actually know something about it, far from everything, but something. But I actually think it's a really neat way to think about a lot of the issues that are fundamental to health policy debates right now, because I'm very fond of this phrase, which is not mine, but it's that mental health policy is a lot like regular health policy, except even more so. And what that means is that all the things that make health policy either really complicated or really interesting, depending on whether you are a policymaker or a researcher, those are all magnified in the context of mental health problems, so or substance abuse as well. So just to give some examples of that, we worry a lot about disadvantaged populations and how they're going to fare with respect to health insurance and their access to health care and affordability of care. Before the Affordable Care Act, if you looked at different subgroups, subpopulations, people with mental health and substance abuse problems had disproportionately high levels of uninsurance and reliance on public coverage. And this just has to do with the basic epidemiology of these disorders. They're more likely to strike earlier in life. Their peak prevalence ages are young adulthood. Young adulthood is when people before the ACA were most likely to be uninsured. Also, mental health and substance abuse problems are very highly correlated with incomes, or negatively correlated with income. So if you have these problems, you're much more likely to be lower income, which means you're much less likely to have insurance. Things around health insurance markets are also really complicated here. And as health economists, we worry about things like adverse selection and moral hazard and how they can make health insurance markets really, really complicated and not function very well. Those are a big issue in any health insurance discussion and how we design benefits. They are an even bigger issue in the context of mental health and substance abuse services. Stepping away from insurance on the delivery system side, people with mental health and substance abuse problems rely on a very diverse set of providers and really, really benefit from having well-coordinated care. Those aren't things that our healthcare system does very well. And on top of that, there are some really significant issues around provider shortages for mental health and substance abuse treatment. And these are just expensive populations as well. And this alludes to something that Jean started off with. We know that there's a small share of people in our population that account for a really significant share of total healthcare spending. If you look in that like top 1% or top 5% of healthcare spenders, you find mental health and substance abuse problems all over the place. So this is a really expensive population, not just because mental health and substance abuse services are expensive, but because people with those problems tend to have lots of other health issues as well. So, and then the final thing I'll just note is that because it gets a lot of attention right now, and deservedly so, we have this raging opioid epidemic, which is really starting to seep into the public consciousness in a very big way and into broader health policy discussions in a very big way. And it is something that really deserves a lot of attention considering how many people are dying daily from this. So where were we at in terms of the Affordable Care Act around these issues? So we had the Medicaid expansions that most but not all states chose to take up as part of the Affordable Care Act because that's more targeted at lower income people. That really did matter a lot for people gaining insurance who had mental health and substance abuse problems. This is actually especially important for opioid treatment. If you look at states that chose to expand their Medicaid programs, Medicaid is now the biggest payer of medication-assisted therapies for opioid dependency in those states. The Affordable Care Act enacted essential health benefits. One of the 10 essential health benefits categories was mental health and substance abuse services. That's a very big deal. And in expanding insurance for people with mental health, especially severe mental illness, it does something really important, which is that if you don't have insurance and you have schizophrenia, you are very likely going to become essentially a ward of the state. Having insurance turns you into an active consumer, which is a very, very different way, and I would say a much more human way of thinking about people with really severe, persistent, and disabling mental illnesses. But it is also really important to note, I would say coverage expansions for people with mental illness or substance abuse problems are necessary but not sufficient for ensuring access to high-quality care. We know that we're starting to learn more and more about how the ACA actually affected access to mental health and substance abuse services, but we are definitely learning that it didn't solve every problem. There's a lot of other things that go beyond insurance per se. So that was where we were at with the ACA. Where are we at right now with things rapidly changing? Well, we have a great deal of uncertainty as we try to understand what are possible repeal strategies, what are replacement plans, what might they look like. There's this big issue of what happens to the Medicaid expansions. If they go, that's going to be very much to the detriment of people with mental health and substance abuse problems that really very heavily rely on the Medicaid expansions. One important feature of the Affordable Care Act was the dependent care expansion, which allowed people, if their parents had private insurance, to stay on their parents' private insurance plans until they turned 26. It used to be in most states, once you turned 18, you wouldn't be able to be covered as a dependent anymore. Because so many mental illnesses have their first onset in exactly that period, that was actually a really, really big deal for this population. I mean, think about something as serious as psychosis. First episode psychosis happens during that period, and we are learning very rapidly how important it is to rapidly access comprehensive services when first episode psychosis happens, and that you can really change the trajectory of psychosis for a person's lifetime if we do that well. So having that crucial young adulthood period covered is really important. So what happens with the dependent coverage expansion and replacement plans is really a big deal. And then the final point I'll just raise is it's not just about whether Medicaid expansions stay or go, but broader questions about how Medicaid should be reformed, which is a really, really big issue in Republican health policy right now. And there is, I think, a very legitimate question to ask from the perspective of mental health policy. On the one hand, flexibility can be a very, very useful thing for Medicaid programs when you're trying to deliver mental health services, which tend to be beyond the typical set of healthcare services. But on the other hand, proposals that increase flexibility, like block granting Medicaid, frequently come at a cost of just capping the amount of money that's going to go into those programs, and the money has to come from somewhere. So there's lots more to talk about, but let me pass it over to Sarah now to talk about public opinion.
Okay, hi. Thanks everyone for being here, and good afternoon. So I was asked to talk about what the public thinks about all of these issues. And to set the stage, I want to bring you back to the time that Jean began with, thinking about 2009, 2010, when President Obama was getting started with the very deliberate effort to make healthcare reform the signature domestic priority. And remember that the House and Senate bills were passed with no Republican votes. And that really set the stage to make this legislation extraordinarily politicized going forward. And we see that in public opinion, and of course we see that in what we're dealing with on the political federal stage today. So as I was preparing for what I wanted to say, I went back and I found a Washington Post article from March of 2010, just after the House had passed the final bill, before it went to President Obama to sign. Remember, with no Republican votes. And John Boehner had a quote in that article that he made on the House floor, and he said, ominously to our 2017 ears, "In a democracy, you can only ignore the will of the people for so long and get away with it." So I think what that means is here we are in 2017, and this law may indeed not get away with it. So a few important facts about public opinion, just to put on the table before our discussion. First is, you all may well know this, but I think it's important from a sort of political science perspective to keep emphasizing just how polarized public opinion is about the ACA. So we see, in general, on average, pretty middling support for the law, and that hasn't moved much at all. So we saw when the law was passed, about 45 to 50% of the public supported the law. That stayed pretty consistent, maybe went down a little bit, but there was no dramatic uptick. There was no increase when implementation was happening and when people started to learn more about the law. And that's a signal that that public opinion and favorability toward the law was really just patterned by political preferences. So only about 12% of Republicans have ever favored the law, and that number is more like 65%, maybe up to 70% at times for Democrats in support of the law. So while people have really strong views about the law, the public knows very, very little about the specific components of the law. So time and again, every month, the Kaiser Family Foundation issues a health tracking poll, which I think from a sort of policy wonk ear is sort of really demoralizing about just how little awareness there is of components of the law. And I think this came to a head for me when I saw the data in 2016, in September of 2016, that only a quarter of the public even knew that the uninsured rate was at an all-time low in our nation's history. So this is like the hugest victory for the ACA, this incredible insurance expansion to more Americans than ever before, and only a quarter of the public recognized it. And another 1/5 of the public thought that the uninsurance rate was at an all-time high in 2016. So the other sort of final interesting point about public attitudes about the ACA is that when people, Republicans and Democrats alike, are asked about the specific components of the law that you've heard about from the 3 previous panelists, they like it. So I pulled data from just after the election, also from the Kaiser Family Foundation tracking poll, which shows that 83% of people who reported voting for Trump support the dependent coverage expansion that Ezra just described. 75% of Trump voters report liking the idea of free preventive services with no cost sharing. 68% like the idea of subsidies for low and middle income Americans to help pay for the cost of care, and 60% support the idea of regulation to prevent people with pre-existing conditions from being excluded from coverage. So what's going on here? There's a huge disconnect, right? So between liking little components of the law but not liking the whole thing. And I think in part there is blame to be made to news media coverage, which tended over the last 6 to 7 years to report on the law as though it were a political campaign, talking about the politics, the political strategy, the political disagreements, and the repeated calls to repeal the law rather than focusing on the specific policy components and especially the Medicaid expansion and the subsidies to provide low-income Americans with help. And my research bears that out. We see that only 1 in 10 news articles that we examined mention subsidies, for instance. So just with that background, I want to end, before we open up discussion, with a few points about where the public is right now in their attitudes towards repeal and replace strategies. There's a lot of polls. Some of you have probably seen these polls. And it looks like a sizable proportion of Americans, mainly, as you can expect, patterned by who vote choice in November. So more Trump supporters than Clinton supporters support repeal. But about a quarter say they think that the law should be repealed. The remainder think it should stay or be replaced with something else. But these numbers move all around, so it's really a case of where we can see that the way you frame it really matters. So people may say that they don't like the law, but they are thinking that it will be replaced with something they like better, probably. And so, interestingly, we're also seeing when people are asked just, do you like the Affordable Care Act, that the highest support for the Affordable Care Act ever achieved in polling was this past Monday. So at about 50% of Americans now say they like the ACA, up about 6%, 7% from even the first week of January. So the take-home point is that people don't like to lose things. And it looks like we're on this precipice of losing things. So we can talk more in the Q&A about what might come next. So thank you.
Wow. Well, to be honest with you guys, do a really hard thing. To, in about 5 minutes, give us kind of the top line of what's important for us to know from the federal perspective, the state perspective, a deeper dive into mental health issues and public opinion. Thank you. You guys did a great job of that. I think each of you kind of addressed this in a certain way, but I want to start by asking each of you to respond to this question. And we are going to throw it open to the audience. And I think there are some cards if people prefer to write questions down. You can raise your hand. Yeah, or if you've got them, pass them to the aisles if you've written questions, or be thinking about questions and we'll just call on you and bring a mic to you. But I'm going to start with a couple. So would you each just answer this question? As Sarah has pointed out, there's a lot in the ACA and there's a lot that people don't know. Would each of you maybe just make one further comment on something that you think is really important about the ACA that the public may not be aware of, that would be really important to have visibility on during this repeal and replace discussion? Jean?
I get picked on first. So, I mean, I think there are clearly a variety of things, but one thing that I think that's really important for individuals to understand, and it's actually a provision that kind of slipped through without a whole lot of discussion, actually, was medical loss ratio regulation in the individual and small and large group markets. This essentially regulates the percentage of an insurer's premiums that must go towards clinical benefits, that is, payment of claims and quality improvement. I alluded to it in my introductory remarks that prior to the ACA in the individual market, 40% of the premium dollar could be toward administration and profits. And what the medical loss ratio regulation did was to basically say for the individual and small group markets, no more than 20% can be going toward those costs, and 15% in the large group market. That's kind of notable because as we think about the Republican proposal or policy ideas that are being put forth, it really peels back a lot of that. And so I think individuals may be surprised at what will get loaded into their premiums going forward.
I would mention in the individual market, when there was the decision to phase out the high-risk pools across the whole country, and Minnesota had one of the oldest and largest high-risk pool, there was consideration by the Congress and CMS about, well, what do we do about the premiums as you move higher-risk people into the individual pool? And they included 3 premium stabilization programs in the law, risk adjustment, risk corridors, and reinsurance, that were intended to help states kind of get through this period of volatility until we understood more of what the market looked like. Well, those programs were not fully funded, or actually not funded at all through political manipulation during the implementation process. They were actually modeled after what was covered in Medicare Part D for Medicare prescription drug programs, and it's worked very well, these 3 different models of premium stabilization, primarily because they were fully funded, they're very accepted, and they were long-standing. So I think had there been sort of a full support of these premium stabilization programs, we might not be in the situation that we're in, and we kind of, just assume nobody thought about it, but they actually had thought about it and had some plans for it.
I'll do 2, but I'll be quick with them. The first is just a political thing, which is to remind ourselves the fundamental ideas behind the ACA did not come from Democrats. They originally came from Republicans. Like, the earliest version of something that looked like the ACA was a plan from 1992 or 1993 that Newt Gingrich was very much behind. And I say that not to, like, poke fun, but to say, like, maybe we can try to start talking a little bit better with each other, and as opposed to they're in favor of something, so therefore I must be opposed to that thing. There really should be more ideological common ground here than I think that we have been allowing ourselves in these debates. So that's just one thing to remind ourselves when we're getting heated about all this stuff. The other, though, is something that I hadn't realized until very recently, which is that we talk about how the ACA really is so important for Medicaid, or so important for the individual market, and that gets so much, the individual market in particular gets so much attention. But if the ACA is repealed, it actually will have implications for people who are the vast majority of Americans that get their insurance from an employer. And one of the things that the ACA mandated was that there are caps on how much you can pay out of pocket in a given year, and also does not allow insurers to have lifetime limits on how much is paid. And that's what insurance is supposed to do. The reason why we have health insurance fundamentally is to protect against these really catastrophic losses. That's the basic theory of insurance. And actually, before the ACA was enacted, lots of employers had those types of limits, which is really contrary to what insurance is supposed to do. 17% of people that had employer-sponsored insurance had some sort of annual cap on, did not have an out-of-pocket cap annually, and over 50% of people that had employer-sponsored insurance had some sort of lifetime limit on benefits. The ACA eliminated that practice, and if it's repealed, that might go with it, even if you are already just getting insurance from your employer.
Yeah, and I just want to emphasize, Jan began by saying we're talking about coverage, but the ACA really pushes the needle on population health and public health more generally. So I want to emphasize a few quick points on that. So most of us think of the ACA as being about the healthcare system, but there's a lot of public health in this legislation. So first, the Prevention and Public Health Fund in the ACA actually funds 10% of the CDC's budget. So that would be a huge hit if that were to go away. And that's funding just sort of bread and butter public health programs. Epidemiology, capacity, tobacco control, immunization programs, so kind of straight public health. And then there's many specific pieces of the ACA that promote population health and public health. Menu labeling, calorie labeling was in that law. Workplace accommodations for breastfeeding mothers, another really important public health goal in that law. Some really ones that probably no one has ever heard of. There was a tax on indoor tanning services and devices in the law to raise money, which also can, as a tax does, lowers use of those services, and we know that indoor tanning is a major carcinogen. So just to emphasize a few.
Great, thank you. I mean, you've really done a great job of pointing out that even though maybe most of the political heat and rhetoric is around certain elements of this, the effects of repeal and depending on what's the replacement strategy, will be felt much, much more broadly. We've got, I'm just going to try to categorize a couple of the questions that folks submitted on cards because they actually are targeted to each of you individually to give you a chance to maybe expand on a point or clarify a point. And I'll try to kind of go in the order that you spoke. Jean, there are a couple questions here about the current discussions from the Republicans about alternative approaches, state waivers being one thing, block grants being another. Can you speak a little bit to what you see as some of the most promising of those ideas?
Sure. So there's, as has been mentioned, there's no kind of definitive proposal yet formed. However, there are some glimpses as to what could be included, and one of the key documents that has been put forth is the document A Better Way, which is out of the Paul Ryan's House GOP group, and that lays out kind of a series of proposals designed to address the principles of providing more choice, lower cost and flexibility, protecting the vulnerable, spurring innovation, and protecting Medicare. So there's kind of a few key buckets, and I'll just kind of give a highlight of them and talk about just a couple of them. The first is quite a lot of emphasis on the use of health savings accounts, which are really tax preference dollars being used to pay for out-of-pocket expenses that individuals incur when they have a high deductible health plan. So there's lots of incremental changes proposed around contributions and who can contribute and how much. The second is the adoption of state-based high-risk pools, which Lynn is the expert on the panel regarding those. There's also two really important tax code changes that are being proposed as a way to really try to level the playing field / increase affordability of coverage. The first is the recognition that employer-sponsored insurance right now, premiums out of the employer share, and in some cases the employee portion of premiums can be paid for with pre-tax dollars. The value of that in aggregate for the U.S. this year is about $266 billion in foregone tax revenue. They're proposing to cap the ESI, or the employer-sponsored insurance tax exclusion, at a level of $20,000 for family coverage and $8,000 for single coverage. Based on looking at what plan premiums are today, that's going to likely affect about 10% of households if that goes through. The other is that in lieu of an income-based credit, as we have under the ACA, one of the proposals the Republicans have put forth, specifically Tom Price in his work, is an age-based credit. So instead of income, the value of the credit for buying insurance in the individual market will be based upon age. So it will increase as you get older, recognizing that older individuals have higher medical expenses. That has really big redistributional effects. The other two, they've proposed several changes to insurance market regulations that will really pull back on what exists in the individual market. One thing I hope we'll get a chance to talk more about are pre-existing conditions and that treatment. I think that's a really important issue as we think about, and it's all in the details for mattering about affordability to coverage. And then finally, Medicaid block grants and Medicare premium support, which is quite the hot potato. All right, I'm going to pass it along.
Okay, Lynn, for you, there's a couple questions, but we'll start with this one. You made an interesting and kind of provocative comment about if we roll back the ACA in Minnesota, given how we have become financially benefited and dependent in the current economic environment on this federal flow of money. You made the statement, if we do kind of repeal the ACA, we could go back from a Minnesota perspective to the 70s. Would you say more about that?
Yes. So our programs, our Minnesota Care program was, as I said, a state-only funded program, and we funded that through an assessment on providers across the state. And that money it's a 2% assessment. It goes into the Healthcare Access Fund, and it was designed to fund the Minnesota Care Program was designed as people who are not quite eligible for Medicaid, but still needed coverage, couldn't afford in the private market. So it was kind of our next tier, just right above the income eligibility for Medicaid. And we covered that up to 275% of the poverty level. Well, that fund is legislated. It's in the legislation. It's going away at the end of 2018. So there will not be any healthcare access fund to pay for a Minnesota Care program. So right now, I think the federal government pays about 70–75% of our Minnesota Care program. And so we would have to go back and think, do we want to have this program, and where would the money come to fund it? So what I'm saying is we would go back to pre-Minnesota Care and start kind of from scratch about how we would design and fund a program if the federal government stops funding our current Minnesota Care program. And the current Minnesota Care program goes, I mean, we can get into a lot of details, but it's from the Medicaid expansion goes to 138% of the federal poverty level. Minnesota Care is 138 to 200%, and then the exchange subsidies are from 200 to 400. So Minnesota Care is part of our continuum of services, and so that's what I mean. We'd have to go back to pre-Minnesota Care and pre-expansion.
Good. Thanks for that. Ezra, could you comment a little bit more on essential benefits, essential health benefits set? I think you addressed that in your comments, but that's kind of how do you think about that? They're both lauded as really necessary and held up as the reason premiums are going up so much.
Yeah, so the ACA mandates 10 categories of essential health benefits. Basically says if you are in the business of selling insurance, you have to cover up to some specified level, provide some specified level of coverage in these 10 benefit categories. And these range from things like inpatient care, prescription drugs, things that are just pretty much bread and butter of any insurance plan, but things like rehabilitative and habilitative services, and notably mental health and substance abuse services, and maternity care services as well is another one that's getting a lot of attention right now. I think that there's two ways of thinking about essential health benefits, and the views are colored probably by like sort of how Sarah was talking about before, where you're coming from ideologically. One view is that this is an insurance regulation that is essentially paternalistic. The government is saying if you are selling insurance or if you want to buy insurance, you have to buy insurance that has all of these things in it. They might not be the things that you personally think you need or want, but you have to buy it anyway. And A, that's paternalistic. B, it's a mandate that you cover something. Whenever there's a mandate that you cover something, it is by definition going to increase the price of that product, because if it's something's covered, it's more likely to be used. Using something costs money. All of that is, well, all of the things about costing money, that's absolutely true. There's another side to understanding why we have essential health benefits, and here I think it's instructive to use the case of mental health and substance abuse services as an essential health benefit. If you do not have essential health benefits, what you have is a scenario where insurers know a lot about what types of people cost a lot of money to insure. And insurers for a very, very long time were able to be very successful in making money by trying to attract the healthier risk pool into their plan and trying to avoid the really, really expensive people. And one of the ways that you can do that if you are insured is by not offering services which are really appealing to the people that you know are going to be really, really expensive. Mental health, so this is one of those areas where mental health policy is just like health policy, only more so. We know that this occurs for lots of different conditions, but especially so in mental health and substance abuse services, because insurers know that if you have a mental health problem, you are going to be very expensive. And it's not just because of your mental health services, it's just everything. You are much, much more likely to be in that top 1% of spending. So if you don't have a mandate, insurers will probably underprovide those services because they don't want to avoid those what you might call bad risks into their risk pool. By having that as essential health benefit, insurers can't play that game anymore, essentially. And insurers are competing, instead of avoiding bad risks, they're competing on how do you serve this population as best as possible, as efficiently as possible.
Thanks, Ezra. Sarah, this questioner points out, as I think probably most people in this room know, but regrettably the public probably does not, that we spend so much more on health care in America than any other country and get relatively less for it from a population, not only a population health perspective, but important individual measures of satisfaction and health care as well. So given all this rhetoric about repealing and replacing the ACA with something better, something that people will like more, presumably that translates to less expensive. Do you think there's any way that we could see the emergence of a universal health coverage system or a single payer system come out of this? And what does public opinion tell us about the viability of that idea?
Yeah, well, that's a bigger question that maybe everyone can answer about the sort of political likelihood of a Trojan horse where single payer comes out at the end. What we know about public understanding of healthcare costs is that people don't like to talk about healthcare costs. They don't like to think about their healthcare as having a cost and having a price to it because it's a very valuable. It's important. It's about life. It's about your loved ones, and it's really hard for people to talk about choosing care that's less expensive because there's a connection made in all of our minds between healthcare costs and quality, and that you want to be able to and be allowed to pay more for a care that you believe will be better, and people have a perspective that values more care. If you can get it, people want it. And so the idea that there's always going to be some form of rationing, you can't get everything you want. The promises that are made politically are fundamentally impossible because you can't cover everyone with a comprehensive benefit set, as Ezra was just getting at. I don't know specifically the data on public support for single-payer type options, but I would just leave it at saying that the trade-offs that the public may not understand the extent of trade-offs required in getting both full coverage and quality and quantity of care that people might prefer to have.
Thank you.
Can I add on to that for a moment? My mantra over the past few weeks is that I'm not making predictions anymore, but here's another prediction. And one of the predictions that I would make actually is if we do see a pretty thorough repeal of the ACA, and at this point, I don't think that's a foregone conclusion at all, but let's say that were to happen, what I think that means for the future of health reform, like we've seen pretty much once a generation, we've seen a really major attempt at health reform in the United States. And I think that the next time it would come around, I think the likelihood that it would be single payer would be significantly increased because people on the more the left side of the political spectrum would say, hey, we tried an approach that was more based on market mechanisms. Look at where we ended up. Maybe we should go all in with single payer. So that's my prediction for a generation from now, which is how I like to make predictions.
Not in the next couple months. Would either of you want to comment on the single payer topic? It's fine if you. It's like so big that I can. Yeah, great. An audience question in the back. Thank you.
Good afternoon, everyone. I really want to comment on the single payer. Whenever the health reform started, I remember driving down here from up north. I was a clinic director up there to a rally over at Northrop in regards to the magic health reform that Minnesota had. Nobody understood at that time what was happening was there was the establishment of another tier of administration, and Gene, I know your numbers are great. I still question the industry that at a minimum our CEOs are making 6-digit salaries of which used to be direct services for poor people. So that's why I kind of get off on that tangent and I won't go there. But in regard to managed care, what has been to date is managed finances. And since 1955, the Indian Health Service has been a single payer. And I can tell you the data that per capita is 1/2 of what the United States of America pays for federal prisoners. It is ration care. There are hybrids which are out there, which I think that is the answer. We pay way too much There's way too much taxpayer dollars paid for subsidies and so on. Whereas fire services, it's all federal dollars. But regardless, there has to be something done because this is out of line. And we need to come together, and as you're so accurate, they ship people in from Canada and tell them these god-awful horror stories about, oh yeah, I had to wait for 3 months to get something, so I came to the States. Well, I've got to wait 3 months for a procedure that I need. And so it's really a PR issue. And if people were to understand what truly universal services were, or some sort of a hybrid of expanding a Medicaid what we have now, and then reducing the age for Medicare participants. That's what I lobbied for years ago. It's much more cost efficient than hiring another 40,000 IRS individuals to make sure that everybody pays their health premium.
Thanks for those comments. Jean, do you?
Points. I mean, I think one thing that is always critical to remember is that the power of the lobby is so significant in D.C. around health reform. I mean, we're talking about a $3.2 trillion economy. When there's that many resources at stake, the lobbying is deployed. And, you know, what killed health reform in 93, 94 was, of course, the insurance industry. For the ACA, there was an awful lot of kind of huddling and compromise that had to, basically, they had to kind of get the buy-in of all of the key stakeholders, including the insurers and the pharma. And I think for the single payer, the uncertainty that comes with what would happen when you have some entity, i.e. a government, setting prices, their power is probably enough to defeat that. So I do think, though, with respect to the appeal for it from the broader population, I think cost is going to be a tipping point. At some point, we're going to get, if prices continue or costs continue to rise, at some point, individuals will start to be willing to call for something different. But it could take a generation.
Great. There were a couple of questions from the audience on not single payer per se, but the governor's proposal to create a public option via allowing anyone or anyone up to a certain income level to buy in to Minnesota Care. So I wonder if panelists have any thoughts about either the, you know, kind of what you think the impact of that buy-in option to Minnesota Care would be. Lynn, might be in your wheelhouse to start with, but if others want to comment too.
Yeah, so I think in the current environment in the individual market where it's so unstable and there are caps in terms of what the health plans said they would accept for enrollment that are implemented across the state by county. Now, Medica has just said they're going to take in a few more beyond their caps, so these are negotiated with the Department of Commerce. But there are areas where there are like one health plan offered. And so in my mind, I think having a Minnesota Care option and allowing people to buy in would create at least one other option, or if there are no other options. So my thought would be triggered by where there's already no competition, adding a public plan and having at least some option for people to buy into the product. And I would say I've been around too long now, but way back when we started Minnesota Care, we did allow people to buy in, I don't know if you remember that, and pay the full premium. And it wasn't a very significant number of people, but it was very important for the people who could afford it. So they would pay the full price of the premium. It wouldn't require additional subsidy. So I'm somewhat in support, maybe not in areas where you already have a lot of competition, but in the areas where there aren't options.
Great, thank you. Anybody else want to take on? Okay. Are there any, I do have some more cards on questions here, but any other questions from the audience? Yes, another one in the back.
One of the questions Sarah brought up was that most people...
Yeah, thank you. There you go.
There we go. One of the questions Sarah brought up is that in a poll, most Americans thought that uninsured had gone up. But what was the significant, when you said that when you said that, what was the interpretation of that? Was it that people don't have access even though they might be insured? Was it that the cost was so high? What was the interpretation when you saw those polls? I don't know if that's a Lynn or a you question. Sorry.
So this was a poll that just asked, like, according, to your best knowledge, the uninsured rate today is, and it was a multiple choice, lower than it's ever been, higher than it's ever been, or about the same. And 20% chose higher than it's ever been. So can I get into the minds of the people that chose that? I would think it's probably because they're hearing a lot about health insurance, that health insurance is a problem, that it was a political campaign issue, that a lot of people were talking about coverage, and it may just be, well, gosh, if so many people are talking about changing a law, well, then we must have a problem, and the uninsurance rate must be really high. So this doesn't speak to the particular people. I don't know their own insurance status who answered the question, but that's what I think that level of misinformation gets at, the sort of sense that this issue is salient in some way, but not necessarily understanding why. Yeah, and half answered that the uninsurance rate is the same as it's ever been. Does that answer your question?
I just wondered, with how many people are actually insured, when you go out there and talk to people among them, just because you have insurance doesn't mean you have access to it. And that's why I was asking the question.
Oh, I see. Yeah. Yeah, no, this question, I think, was fairly narrowly targeted to the rate of people without insurance. Asking people about access to care, you're right, it opens up a completely different conversation and problem. Yeah.
Thank you. Obviously very worrying at the moment. I have two questions, and one is I'd be very interested to hear you as educated panelists what you think would be good moves right now. We've heard commentary, but be interested to hear if you have ideas that at this time would be useful to follow. The second thing, and this is a question I've always wondered, with life insurance, car insurance, it's predicated on avoiding ever having to use it. And I wonder, is there a philosophical shift necessary to turn it into a service that should be used? Would that have any contribution to changes right now?
Yeah, just on your second point there, that to me that really gets to the single payer argument, that the insurance model is sort of backwards one when it comes to something that we want people to use, and that's perhaps some of the logic that we could see an increase in thinking that way if indeed the competitive market and a market that cost shifts more and more to individuals does leave these gaps or does have these kind of backlashes that we're seeing now. So that anybody else want to comment on that kind of just that whole insurance paradigm?
I'll just take one brief comment relating to this idea. So in terms of thinking about kind of the benefit design, right, when we're thinking about what we want to achieve, right, we want to provide that risk, that financial protection for kind of large risks. And so, of course, high deductibles have become increasingly prevalent, and that has some value. What we know in the literature, right, is that relative to a very comprehensive preferred provider organization, spending is about 5 to 15% lower among people who have a high deductible health plan. Where that sometimes gets crowded out, it's around the savings come from pharmaceuticals, but also from things like preventive care, which is now covered, but other types of, some of these predate the ACA. So there's always kind of the risk that people will sacrifice certain things that may be of value because of that out-of-pocket cost sharing.
Right. And to the first question of some positive news, positive ideas in this environment, what would you, Lynn, you already offered a few ideas for Minnesota. What else would folks have to say?
What I'm hoping, and based on, so the person who they put in charge of the Center for Medicare and Medicaid Services came from Indiana. She's a state person. Indiana has a big waiver of their Medicaid program, and what I would, what I would like, my vision would be for the federal government to keep the money that they have coming to the states. So the APTC tax credit money and our Minnesota Care program, and allow us and then give that to us maybe even as a block grant, that portion, and allow us flexibility to do our own, our own fixes. Kind of let us do what we need to do in the state of Minnesota, and through a waiver, but allow flexibility. And I think that would be. I'm hoping there's state flexibility in the future. I think there's been enough talk about that, and I hope the state flexibility comes with the money.
With the money. With the money. Key caveat there. So the ups and potential downs of block granting. Flexibility, great, as long as you don't. There's a term for this actually. That's it's called block and chop. So part of the political motivation for block granting is to, under the guise of this is going to be more streamlined, more efficient, more flexible. Therefore, you won't need as much. So I think that's the worry. Ezra, did you have something you want to add? No? Okay. Anybody else on the what's positive? What are some good ideas in this environment?
So one thing that is in a variety of the Republican proposals that I think I personally like, and this is health economists have a joke that we are the only political constituency in favor of this, is some way of at least eating away at the preferential tax treatment that employer-sponsored insurance gets. This costs the federal government, I think it's to like $400 billion a year, $300 billion a year, and it isn't good policy. Really encourages people to have their health insurance tied to their jobs, which I don't view as being a desirable thing, and it's not very popular politically, but I do think it's good policy, and to the extent that it's good policy and it's showing up in some of the Republican policy options, I see that as somewhat encouraging.
Good. Thank you. Dr. Mosser.
Suppose that we do get a lot of freedom for states to go their own ways with the money. What are the prospects for single payer in a single state? Seems to have failed in Vermont, was voted down overwhelmingly in Colorado quite recently, so it doesn't look very good. But is that because of certain features of the current situation that could be changed if there were broad latitude given?
Yeah, well, the main word is ERISA. So that's the Employment Retirement Insurance Services Security Act. So ERISA governs pension plans. It's a federal law, and it also has regulation over employer-sponsored insurance that's self-insured. So about 50% of our private market is self-insured, including the University of Minnesota, including the state of Minnesota. So the state has no regulatory authority over any of those plans. So in order to do single payer, you would need all of that buy-in from the self-insured market, because we don't have any regulatory authority to tax them for health insurance, and you'd have to have them bought in. So I think ERISA prevents us from sort of even starting there. What happened in Vermont is they do have a very small market, and just a couple insurers. What they did was they took the tax deductibility out of and the cost of the health insurance out of those employers, and then said what it would cost. And the tax was about a 40% tax increase for those employers, and they basically said, no, we're not going to do it. So it's kind of the trick of getting the self-insured group into the discussion, and then willing to pay an explicit tax as opposed to an implicit sort of tax that they don't see and nobody knows about.
Okay. This is probably way over my head, but suppose the replacement ACA, if you'll allow that phrase, changed ERISA so that states who wanted to do certain things would not have to comply.
So even under that scenario, and I would say I think that's an unlikely, it's not impossible, but I would say an unlikely scenario that ERISA would be amended in that particular way. There's still, the money still becomes very, very tricky, because if you want to enact a sort of state single payer, the funds are going to have to be raised from somewhere. So that's one issue. But the other issue is that if you have to raise the funds. People don't like having taxes on them, so that puts a constraint on how much money you can raise, which means that money's come somewhere. Benefits might not be as generous as we might like them to be for that state single payer plan. If you are among the majority of people that is privately insured already, there's a good chance that your benefits that you get from your employer are going to be more generous than what they would be under that state plan. I think that creates a really politically difficult scenario that prevents progress towards that goal.
Well, clearly this topic of, more unified financing and simpler approaches to coverage it has a lot of interest, and I'm sure will continue to be part of the dialogue, whether federal or state. Any other questions from the audience? Okay, there are a couple more by card here. A couple of pretty specific questions on what do we know about the impact of the ACA on rural healthcare, rural hospitals. Have we seen fewer closures? Have we seen improved access? Have we actually seen less access because of some of the ways the insurance market has perhaps not been as robust as we had hoped? What do we know about rural healthcare?
I don't know specifically about the ACA impact on rural. I mean, rural hospitals have a lot of pressure on them in general just because they don't have a lot of patients in their areas. And we have a lot of rural hospitals spread out all over the country, but particularly in Minnesota, we have a lot of rural hospitals in very small towns. They're very important to those towns, but not a lot of revenue coming in. The ACA would have been helpful in terms of the Medicaid expansion and low-income rural, but I think the ACA was not, a solution to rural health care. That continues to be sort of an issue of what kind of health care is available and how much we pay for it, and is the hospital-based center the right treatment model?
I would just want to add with regards to the individual market in rural counties and rural kind of geographic areas. This group has really been hit very hard because historically they've not had a very large number of insurers present in terms of getting the competitive benefits for the pricing. But we've also seen, we just haven't seen good presence of insurers more recently in rural areas. So there's many states where in those rural kind of counties they have a Blue Cross Blue Shield. In fact, in 95% of rural counties that were monopolies, one insurer, it was Blue Cross. And now Blue Cross, of course, is facing pretty significant losses. So that's a real predicament. And I'm not sure that it's going to be easily fixed, even if we do a repeal. I will say one thing that the Republicans have put forth as a key issue is to allow insurers to sell across state lines. So getting in again to some of the changes in the regulatory framework. This will be an interesting issue to watch as well. There's very little work on this. I happen to have done one of the pieces of that research, a simulation exercise with colleagues here. Interestingly enough, they advocate for it very strongly. In our work, what we discovered, of course, is that the differences across states in the regulations, the mandates, those effects on premiums vary from 0 to 100+%. So the range is wide, which means the potential benefits are also wide, and there's a whole bunch of issues around that. So I'm not sure that's going to be a solution, but yeah, rural areas will continue to be a challenge going forward.
Another question from the audience had to do with the role of some of these innovation companies that are popping up, either in the technology arena or new approaches to coverage. A few that are mentioned, Bright Health here, headquartered here, Oscar, to the extent you guys are familiar with those models, do you think that the design features of those kinds of plans might be successful in addressing some of the shortcomings of the more prevalent insurance model?
So the caveat that I'm not incredibly familiar with them. I'm somewhat more familiar with Oscar than I am from Bright, in spite of Bright being headquartered here. I hope they are. I mean, I always love to see more competition in markets to make health insurance markets work closer to the way we hope that they might. I mean, my understanding of Oscar, and my co-panelists should certainly correct me if I'm wrong, is that it is more of like a narrow network plan. I don't see narrow network plans as being inherently bad. I think they can actually be a very, very useful tool for breaking down healthcare spending and hopefully doing a better job of coordinating care. They can. I don't think they necessarily will be. So this is the thing that I think these are new companies. It remains to be seen. I do hold out hope that they will be successful, but it's far from a foregone conclusion.
Anybody else have a perspective or thought on that?
I would just add that in terms of thinking about, and there's clearly a lot of interest around narrow network plans, which I think is going to continue on regardless of whether the ACA does or not, just because of the challenge around premium growth. But I do think it also raises a really important question about how we're going to make sure that consumers are educated and understand their benefits as they get increasingly complicated. This is a feature that insurers, the network, is a feature that insurers are really working to strategically alter, not only to get lower cost, higher quality providers in, but to reduce premiums by narrowing that network and selecting only certain types of providers. Consumers may not be thinking about those things when they're making their purchase, and I think that's going to raise an important issue for researchers to focus on how we better educate consumers about health insurance literacy.
Not seeing any more hands from the audience. We didn't get to all the questions, so if your question didn't get answered and you want to come on up and ask it of the panel individually, please do. We're at our hour of adjournment. I thank the panel. You guys are a fountain of highly relevant information. So, Tim, great idea. Making the resources that we have here at the University and the School of Public Health visible and sharing that knowledge with you so that we can all be smarter participants in these debates is a great idea. So thank you all for coming. Thank you again, panel. Have a good afternoon.